So hey everyone, welcome back again, and in today's video we will see how to do the general physical examination, and we are basically exploring the theoretical part. So the link to this PDF is given in the description box. So this PDF is available in my Telegram channel, you can go and check it out. So today we will be discussing it and what are the aspects of the general physical examination theoretical part, what are the things that you are expected to answer in your viva, and not only in the viva but also for your clinical examination part. So let's begin this video. So first of all, we see few things that we are going to discuss today. A few things like vitals, which includes the BP, which includes the pulse, which includes the respiratory rate, SpO2. So these are the things which we will see in the vitals. Along with it, we are going to discuss about the temperature. Then we are going to discuss about the pallor. Then we have the icterus. Then we have the cyanosis. Then we have the clubbing, and then we have lymphadenopathy, and then we have the edema. So it is basically pickle, P-I-C-K-L-E, which is the pallor, icterus, cyanosis, clubbing, lymphedema, and lymphadenopathy, and then we have the edema. So these are the things that we are going to discuss in this video today. So let's begin with the pallor. So what is pallor? Pallor basically means paleness of the skin and the mucous membrane. Normally when we see our mucous membrane and the skin, it appears to be slightly pinkish. So pallor is a condition in which you see the paleness of the skin, the pinkishness, the color is reduced. So what are the sites that we examine to see what are the sites? So first of all, part that we see and most commonly what we examine is the lower palpebral conjunctiva. We will see the picture again, and then we use the site, we see the site that is the tongue, then oral mucosa, palmar crease, and nail bed also. And if the nail bed is showing pallor, then the hemoglobin levels are approximately less than 8 gram per deciliter. Then we have the gradings of the pallor. So mild pallor is not detectable clinically. So whenever you spot a pallor in the lower palpebral conjunctiva or any of these sites of examination, what you have to tell the examiner that moderate pallor is present. You can't say mild because mild is not clinically detected. So we say that moderate pallor is present. Severe is said when clinically visible pallor is present along with the following one of the following features. First is the palmar crease is disappeared, and you hear a cervical venous hum, also known as the Pontin's murmur. But there are some conditions which are associated with pallor without anemia, because most likely anemia is causing pallor, but there are few conditions which causes pallor but they are not anemia, other than anemia. So the first conditions, and because these are since it is a exceptional conditions, they are frequently asked by the examiners. So the first condition is hypopituitarism, second is hypothyroidism, then hypogonadism, shock, and left heart failure. Obviously left heart failure and shock, you understand that the blood circulation is less, so pallor is there. Also same as in case of hypothyroidism and other conditions also. So these are the conditions in which anemia is not present, still pallor can be seen. So now we will see what are the sites that I told you. This is the lower palpebral conjunctiva. As you can see, this is the normal condition in all of us, and this is the pallor which you see in the patients having anemia or all the conditions that I told. Then second site is the tongue mucosa, oral, this is the tongue. You can see the pallor in the tongue. Then you can see the healthy pink nail bed, pales on the pressure, and this is the pale nail beds in anemia, what you see in nail beds. Then this is the prominent palmar crease in a patient with having good health, but this is the case of the anemia. And if the palmar crease is having is disappearing or is very faded, then you can say it is a severe case of pallor, or it is a severe anemia. So this is all about the pallor part. Now let's talk about the icterus. What is icterus? Icterus is the yellowish discoloration of the skin, mucous membrane, sclera, and blood vessels secondary to increased bilirubin. Okay. Why we say that in the sclera or the blood vessels and these skin and the mucous membrane? Because the bile pigments have a very high affinity for the elastin tissues, that is why they get deposited in these areas. So icterus is appreciated in these areas. So So what are the sites that you look for the jaundice? So the first site is the sclera, then we have the sublingual mucosa, oral cavity, palm and soles, and the skin. Actually we are saying sclera, but it is not exactly the sclera, it is the upper bulbar conjunctiva, right? So it is written scleral, but it is not actually sclera, right? So we have the sublingual mucosa, then we have the oral cavity, then we have the palm and soles, and then the skin. So depending upon the levels of the bilirubin, and we categorize it as different, just like we categorize the pallor. So we categorize the icterus also. So first you can see that this is the normal levels of the serum bilirubin, total serum bilirubin, and then when it increases from 1.2 to 2.5 milligram per deciliter, it is called as the latent jaundice, but it is not appreciated on clinical examination. What is clinically appreciated when it becomes more than 2.5 milligram per deciliter? So what we said, that yellowish discoloration of the skin and the mucous membrane due to the bilirubin levels, but there are few conditions, just like we discussed in pallor, that there are some conditions which cause pallor without anemia. There are conditions which causes the yellowish discoloration of the skin and the mucous membrane even though when there is no jaundice. So the first condition is hypercarotinemia, because it contains carotenoids, and there is no affected sclera, because the sclera or the conjunctiva is, as I said, is having high elastine tissues, but the beta carotenoids which are increased in the blood are not having the affinity for the elastine tissues. That is why they are not affecting the sclera. Now the second cause is the hypothyroidism, again because there is decreased metabolism of the carotenes, that is why it causes yellowish discoloration. Then we have some drugs like the quinacrine intake, and there is excessive exposure to nitric acid or phenols. These are also the conditions which cause yellowish discoloration but without the jaundice. These are very important questions for your viva, since these are the exceptions. Now we have some different types of jaundice based on the scleral color. So first of all is the lemon jaundice. So the first of all, it is lemon yellow colored sclera, which indicates that it is most likely hemolytic jaundice. Then it can be due to it can be obstructive jaundice if you can appreciate dark yellow color, or it could be long standing obstructive jaundice due to conversion of the bilirubin to biliverdin. Then you see greenish dark yellow. Although these are not much very appreciated, but you can observe these things. So this is, as I said, this is the sclera which you see the yellowish discoloration here. In the palm and crease, as I said, you can appreciate icterus here, and in the sublingual mucosa, as you can see, there is the icterus is appreciated. So this was all about the icterus. Now let's move on to understand what is cyanosis. So after we have completed the icterus and the pallor, now it comes to the cyanosis. Cyanosis is also a very much important sign, especially when you are talking about the congenital heart diseases. Now let's learn about the cyanosis. Cyanosis is a condition in which there is bluish coloration of the skin and mucous membrane, which is because of the increased quantity of the reduced hemoglobin, deoxygenated or hemoglobin derivatives, that is the methemoglobin or self hemoglobin, in the small vessels of these tissues. And the criteria is very important when you need to remember that the deoxyhemoglobin is more than 5 gram per 100 ml of the blood, then it is called the cyanosis. So there is classification, there is true cyanosis and there is pseudo cyanosis. We will discuss each in detail. True cyanosis, according to the sites involved, it is central, peripheral, or it could be mixed, that is both the central or the peripheral. So as you can see, this is the cyanosis in the hands. In the hands you can see the in the digits, in the distal part you can see the cyanosis. Then in this lip you can appreciate the cyanosis here, and also in the ear lobules you can appreciate the cyanosis. Now when it comes to the central cyanosis, you have the three causes: cardiac cause, pulmonary cause, or some other causes of the central cyanosis. So in the cardiac cause you have T, 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 yani 5 T's, 5 T's, 5 T's and 2 E's. So what are these 5 T and 2 E's? First is truncus arteriosus, then we have transposition of great arteries, TAPVC, TOF, tricuspid atresia, absence anomaly, and Eisen-Mengerization. All of these are the cyanotic congenital heart diseases. Eisen-Mengerization is the also present in this discussion. What is Eason mineralization? Let me tell you that Eason mineralization is a condition in which there is formation of the as we can say, in case of a long standing left to right cardiac shunt, there is pulmonary hypertension, and eventually there is the reversal of the shunt into a cyanotic right to left shunt. So, this is the Eason mineralization syndrome. This is the all about the cardiac causes. Now, when it comes to the pulmonary causes, then you have all the COPD, then cor pulmonale, asthma, and respiratory failure of any cause like pneumonia, tension pneumothorax, massive pleural effusion, and acute causes also. Then we have some other causes of the central cyanosis like the high altitude polycythemia, endogenous or pigment cyanosis like replacement cyanosis due to some endogenous chemicals like the methemoglobinemia, sulfhemoglobinemia, or it could be carboxyhemoglobin also, which causes the cherry red pigmentation. So, basically central means in peripheral means in all the peripheral part, that is the extremes of the body, and the central means in the central part of the body like the nose. Then we have the in the peripheral part you have the ear lobules, also your along with the ear lobules we have the fingers. In the fingers also you can appreciate the cyanosis. In the central you have the tongue, in the tongue you can appreciate the cyanosis also. So, this is about the cyanosis. Then we have the peripheral cyanosis causes like this low cardiac output, then we have local vasoconstriction like the Raynaud's phenomena, cold or frostbite, then arterial and the venous obstruction, then hyperviscosity syndromes like the multiple myeloma or the polycythemia, then we have the cryoglobulinemia. Then we have the mixed cyanosis, which is left ventricular failure, in which you can appreciate both the central and the peripheral cyanosis. Also, we talked about the pseudocyanosis, in which there is not increased deoxygenated hemoglobin, but still you can see the cyanosed bluish discoloration. So, these conditions include due to drugs, or it could be due to metals. For the drugs you have the minocycline, chloroquine, amiodarone, and in the metals you have gold, silver, mercury, and arsenic. Now, we have some atypical presentations of the cyanosis also. So, we have some atypical presentations. What are those? Let us study one by one. The first is the differential cyanosis. What is differential cyanosis? Differential cyanosis means that you can appreciate the cyanosis only in the lower limbs. For example, this is seen in the case of the patent ductus arteriosus with Eason mineralization, which I already told you that due to long standing left to right shunt there is pulmonary hypertension, and this causes the reversal of the shunt from left to right to left. This causes cyanosis. So, in the case of patent ductus arteriosus, which is a acyanotic heart disease, it gets converted into cyanotic due to the reversal of the shunt. So, this is a cause of the differential cyanosis. Then we have the reverse differential cyanosis, in which cyanosis is seen in only the upper limbs. It is seen in PDA with Eason mineralization plus transposition of great arteries. So, this is the reverse differential cyanosis. Then we have 3/4 cyanosis, which means in addition to the lower limbs you have the left upper limb may also be cyanosed. So, out of the 4 limbs you have 3 are affected, only 3 are affected. So, this is called 3/4 cyanosis. It is seen when the opening of the patent ductus is opened proximal to the origin of the left subclavian artery. Then we have intermittent cyanosis, characteristically seen in Epstein's anomaly. Then cyclical cyanosis seen in bilateral choanal atresia. Orthocyanosis means that the cyanosis is developed only in the upright position due to the hypoxia in the erect posture. It is seen in pulmonary AV malformations. Then we have the cyanosis which is absent despite reduced hemoglobin. It is seen in anemia and carbon monoxide poisoning. It is seen so because the amount of hemoglobin is already reduced. So, the amount of deoxyhemoglobin will also be reduced. That is why you cannot appreciate the cyanosis in case of anemia if it is very severe. So, this was all about this cyanosis, and then we see the difference between the peripheral cyanosis and the central cyanosis. Central cyanosis is due to inadequate oxygenation. Peripheral cyanosis is due to sluggish peripheral circulation. Central cyanosis is hypoxic hypoxia. This is stagnant hypoxia. Then we have the sites of the examination, which I already told. In the central cyanosis, we appreciate the tongue, the oral mucosa. But in case of the peripheral cyanosis, we see the tip of the nose, ear lobule, then the outer lip, fingertips, nail bed, and the extremities. In the case of the central cyanosis, the extremities are warm and the peripheral cyanosis extremities are cold because this sluggish circulation, so the temperature will be decreased. On rewarming the patient, the central cyanosis does not improve, but in case of peripheral cyanosis it improves. The partial pressure of the oxygen is less than 85% in the central cyanosis, as we said that it is due to inadequate oxygenation, but in case of peripheral cyanosis it is well above the 85 and in the normal limit. In the central cyanosis you can see that upon giving oxygen it improves, but here there is no improvement, right. In this case the high pulse volume or the dyspnea is seen, here it is absent. Exercise may worsen the central cyanosis, but the exercise may improve the peripheral cyanosis, because exercise causes the vasodilation and there is increased circulation, that is why it may improve in the peripheral cyanosis. Central cyanosis may be associated with clubbing and polycythemia. So, this was the difference between the central and the peripheral cyanosis, and again a very important question for maybe not for your viva only, but for the theoretical part also, that is the hyperoxia test. What is hyperoxia test? Hyperoxia test is a important test which we use to differentiate the cyanosis caused due to cardiac conditions or due to the pulmonary conditions. So, what we do that after giving 100% oxygen for 10 minutes, we repeat our ABG test, and if the partial pressure of the oxygen is less than 150 millimeter of mercury, then we know that the cause is cardiac. But if the PaO2 improves to more than 200 millimeter of mercury, then the cause is the respiratory. So, this is a very important test that we perform to differentiate between the cardiac and the pulmonary cyanosis. So, this concludes our cyanosis also.